Thank you so much, organizing team, for inviting me. So just now, sir has mentioned that VATS is the progress forward, but I will put forward some facts, okay? And let's see those facts, what they say. Is it really worth to do VATS, which is so much expensive as compared to your fibrinolytics? So So as introduction, empyemas are significant cause for morbidity and fortunately not mortality in children. This is very important sentence. So there are differences between adult and pediatric pleural infections. The principal one is that since it is rare for children to have underlying lung disease, the final outcome is almost always excellent. And this is the studies which have mentioned. Paranemic effusion and empyema have incidence almost 3.3 in thousands. So empyemas, we have different stages like exudative stage, we have fibrinopurulent stage and organization. As I rightly mentioned, we don't know when patient comes to us. But nowadays it's very easy to diagnose a paranemic effusion because of availability of X-rays in all the places as well as scans. So what this study mentioned, that presence of septation, that is fibrinous strands within the pleural fluid, does not necessarily mean the fluid does not flow freely. So this is very, very important point to mention. And although separate location will not communicate with each other, but that does not necessarily that fluid is not moving with, there is no free flow. So this is the suggestion how to go about. So what are the outcome and prognosis? As already mentioned, the majority of follow-up studies have shown that despite the heterogeneity of treatment approaches, the majority of children make complete recovery and their lung function returns to normal. The chest radiograph returns to normal in majority of children, that is almost 60 to 83% by 3 months of age and over 90% by 6 months of age, and in all 18 months. So this is very significant and this is very good to say that the prognosis is very good in empyemas. Microbiology. Why I'm stressing on microbiology? If you know the microbiology, so main common cause in India is Streptococcus. Of course, beta hemolytic streptococci like Pyogenes and Staphylococcus aureus comes later, but Streptococcus pneumoniae is the most important causative factor. And of course, nowadays we see Mycoplasma pneumoniae as well as Pseudomonas, and certainly adenovirus and influenza virus can cause effusion, but they are rarely. So investigation, ultrasound is third eye in a pediatric practice for at least for a pulmonology perspective as well as ICU perspective. CT scans are unnecessary for most cases, used only in complicated cases and before surgery. So let's talk about treatment. So conservative management, antibiotic and simple drainage in a pleural effusion or empyema is more than enough in almost more than 60 to 80% cases. This study has been done in Turkey and which has shown that if you give proper antibiotic treatment, which is targeting your streptococcus as well as staphylococcus, then the success rate or the success rate going into the stage 3 of empyema are very, very rare. So antibiotics, I would say probably the most important weapon. So all cases should be treated with intravenous, and oral antibiotics should be given at at least 1 to 4 weeks, but longer if there is a residual disease also. Now very important, as the previous speaker has rightly mentioned, it is very difficult who should insert the drain. It's not difficult science. So if anybody can intubate, it's easy to put ICD drain, but it requires little bit of training perspective. So who insert? Mostly pediatric surgeons, or if suppose somebody who is trained pediatrician also can insert. So like in a newborn period, they usually neonatologists only put the ICD drainage. So it's easy to learn this rather than doing the VATS, which is very, very expensive. What about intrapleural fibrinolytics? So what they say is it lies the fibrinous strand located empyemas, thereby clear the lymphatic drainage and effective filtration also. So the most of the pediatric case series children reported, almost 136 cases treated with streptokinase or urokinase alteplase, all indicate that increased pleural drainage with these agents and overall successful outcome without surgery is almost 90%. That is huge. So I'm not against anybody, any procedure or anything, but we have the facts. Failure rate of medical management is low nowadays in children because of good antibiotics availability as well as good also intrapleural fibrinolytics. So this is the dosage what we can use in our usual practice. Both are easily available in India. You can use in, not necessary to have a tertiary care center, you can use it in primary as well as secondary care center also. Let's see this. This is MISS study by Sonappa et al. What it says, it's a randomized control trial, and what they said, they found that median duration of hospital stay post intervention was similar in both the groups. So this is very, very important. Not so the stay, what the previous speaker has mentioned, that stay reduces the but cost as well as the ultimate result is remains same. Peter et al. Has mentioned, so they have done this a study on 36 pediatric empyema patient. What they have seen, that both these studies showed that VATS was much costlier than fibrinolytic therapy, and though there is a single center trial. In the recent multi-center trial conducted by Marwanda et al., what they have found that, the above studies indicate that intrapleural fibrinolytic and surgical debridement are equally effective, but surgical therapy might be associated with more cost. And India being, developing country, I think we should not advocate for a child who is not affording. So this is the latest. This is latest 2023. What it mean, what it's showing, so this is from USA, and what it's showing is that percutaneous drainage with fibrinolytics was associated with lower index admission cost, shorter hospital stay, lower rates of readmission compared to operative drainage. So what do you mean operative drainage is nothing but VATS procedure. So this knowledge should be used in improved selection of this treatment in patients. So ultimately it's us to decide which treatment is necessary particular for that particular. What about complex empyema? What option do we have? So study by Matthew et al. Says, considering intrapleural streptokinase even in this presentation, especially a resource limited setting. Also Singh et al. Has mentioned that children were operated only when they had significant clinical symptoms in the form of persistent fever or respiratory difficulty. Let's talk about some other than fibrinolytics. Treatment with sonographically stratified multiloculated thoracic empyema by medical thoracoscopy. Safety and efficacy of medical thoracoscopy in management of loculated thoracic empyema. So conclusion in all these studies have mentioned that loculated pleural empyema could safely and successfully be treated by medical thoracoscopy. So we might be, because we need only one port to put in, and this thoracoscopy is nothing but it's like putting a chest tube and then examining the complete. So examination of pleural cavity and performing various diagnostic. So if performing simple procedure like pleural fluid drainage, removal of loculation, pleural biopsy, you can do, even pulmonologists can do it, but again, it requires training. Indication of thoracoscopy, as I have just now I have mentioned, there is contraindication like VATS. If lack of pleural space, it's an absolute contraindication. Poor general condition, hemodynamic instability, hypoxia, too much of hypoxia and coagulopathy can be a contraindication. Tools required are very less, and it's not expensive. So just I'm putting a highlight on this new modality of treatment for this. So ultimately, this is the algorithm which is followed all over the world. Stage 1, physician give no intervention. You just continue with antibiotics and if required aspiration. Stage 2, early or late. If it is early, you can go for ICDT and fibrinolytic agent. Still, you can consider involving surgeon and continue with antibiotic as fibrinolytic if that gets failed. And stage 3. So I am not saying that VATS is not good option or something. It's what stage you are applying that surgical intervention is very, very important. Before that, you can definitely try for which is non-surgical. So contraindication cannot be done in pleural window. There is a thick pyogenic material in presence of fibrotic rings. In this situation, you can go for thoracotomy rather than VATS. Relative contraindication, I think this is the biggest contraindication in India, the cost and availability of trained personnel. So however, what is the standpoint of now? So however, the current standing guidelines by BTS and American Surgical Association says considering intrapleural fibrinolytic as a treatment of choice followed by VATS if the former fails. New emerging therapy which is cost effective and less traumatic like medical thoracoscopy is going to change the scenario. So this is the way you can deal with your patient who are having empyema. Dear past, thank you for all the lessons. Dear future, I am ready to accept if comes in the future some new guidelines. Thank you so much.
Thank you, Dr. Sagar Varankar. And now the audience, if you have any questions to these two people.
Sir, I do not have any question, but we have a Child Health Institute in Bangalore, Indira Gandhi Institute of Child Health. So I would just like to draw the attention of the audience that there has been a paper presented by the pediatric surgeons of Indira Gandhi Institute of Child Health, and a pediatric surgeon saying that fibrinolytics are the first choice as compared to VATS is something that's shareable.
Yeah, I think, thank you for that comment. I know Dr. Ramesh very well personally, and this study came out in the Journal of Pediatric Surgery, and they have done, I think, 45 odd patients, randomized them into receiving fibrinolytics versus VATS, and their conclusion was that, results are pretty similar. In fact, if I recall correctly, fibrinolytics and drainage had a better success rate than VATS. So the unfortunate part of this, and this is what I was trying to say in this talk, is that we have very few studies from India. All the studies that my eminent opponent showed, everything, I was noting all the references, there was nothing from this country, and that's the problem. Somehow or the other, our pediatricians and our friends with pulmonologists are very reluctant to do this. I've spoken to our pediatricians who run our PICUs, where we get most of these referrals from. And they say there are some practical problems. I mean, like I said, putting in an intercostal chest tube, then how are you going to give this fibrinolytic? That sometimes is the problem. 3 ways don't fit. How do you manage to give this in a sterile condition? There are issues that they face. So I think we should sit together and work that out. And there is no doubt that this works. No one is saying that. The question is, as I said in that last slide, has the pendulum swung too far? At one point of time when I was training, we were told that do an early VATS. Patient is toxic, having fever, still put in a scope, get everything out. Now, that was going too far. Similarly, now maybe the pendulum has swung too far to the other side, that everything, don't think of VATS, just do fibrinolysis. The patients that we very often see, unfortunately, do come late. And this is a problem. Maybe if we can do fibrinolysis in setups which are in the periphery, that would be a great help. Thank you. I have not had to do a patient who has failed a fibrinolytic therapy because very few of them get done here. But there are studies that show that it can be difficult. There are a couple of papers which show that a lot of these patients don't do well with VATS. They have to convert to a thoracotomy, which then makes it very difficult, right? So that's it.
So that is why I said we have to be in continuum with each other. So that's why the stage 2 early late. So you have to involve surgeon. I'm not denying the part of surgeons, but it's not, availability is not everywhere. So that is the reason we should. That's the reason. So if you say out of 190%, empyemas are treated by primary pediatrician in their small setup where availability of doing surgery like VATS is little difficult.
Yeah,
I think
so it's a complementary to each other.
I just want, I'm Dr. Anil Sachdev from Gangaram, Delhi. Recently, 6 months back, I had a presentation on the same topic, and I reviewed this literature, whatever you both have presented. So my conclusion was the papers presented by the surgeons favor VATS, and papers prepared by the physicians favor fibrinolytics. That is the conclusion.
So probably the audience has got the answer.
Sir, what are the reasons of failure of?
Settle the matter. So I think everybody has got the answer. So can we switch to the next topic?
Small
Yeah,
questions. So what are the reasons of failure of chest tube with fibrinolytics? apart from the stage of the disease?
So, no, the important is stage of the disease, because once it becomes thick, it's very difficult to lyse the septations. So that is the reason for failure. Second is, till now we didn't know what is the dose of, actual dose for fibrinolytic and how many days to give. So that is the another reason for failure. And dwelling
Thank
time.
you.
And dwelling time.